quick introduction. My name is Natalie Spitzer, and I am the program consultant for Michigan. I work with the hospitals that are participating in our Rural Healthcare Outcomes Accelerator. I have been with the American Heart Association for a little over 2.5 years now, and I've been working on this project for that whole time. Um, and joining me, as I said, is Mindy. I'll let her introduce herself, and then she's going to kind of kick us off with the presentation.
Great, thanks, Natalie. I don't know who's controlling slides. Are you controlling and advancing or?
Yep, I have them.
Okay, can you go to the inner slide, please?
Sure. Oops.
All right, well, welcome everyone, and thanks for having us here today. As Natalie mentioned, my name is Mindy Cook. I'm our Senior Director of Rural Healthcare Quality here at the American Heart Association. I've been at the association it'll be my 14th year this year, and time has just flown by. Worked and done a lot of projects in the upper Midwest in my tenure, based in Minnesota, and currently leading our Rural Healthcare Outcomes Accelerator and National Strategy for Rural Quality Care. Today, I think we'll turn things over and have a great presentation from Angela Schiller later on to talk about her experience in the program. But I'm going to just share a little bit more about the Accelerator and our rural quality programs and a little bit more about what Natalie and I do to support this initiative. So we can move on. So in 2022, we launched the Rural Healthcare Outcomes Accelerator program. It was in response to a presidential advisory that we published in 2020, really calling attention to some alarming trends with diverging outcomes in rural versus urban America. So our rural residents, which I and many of you live in rural areas, identify as experience a 3-year lesser life expectancy, a 40% higher risk of cardiovascular diseases, and a 30% higher risk of stroke. So we looked at what we could do with our many programs to try to bring the 3 areas of opportunity back into alignment with some of our rural residents. The 3 areas were really our healthcare quality, access to care, and risk factor mitigation. So, of those 3 areas, we have some impact with our quality programs on 2 of those. And Natalie and I again work on our quality programming for cardiovascular diseases and stroke. And within that space, specifically for acute care hospitals, we launched the Rural Healthcare Outcomes Accelerator, really offering access to a comprehensive quality program hinged upon our Get with the Guidelines, stroke, CAD, and heart failure modules that are registry-based quality improvement programs to help hospitals ensure they're adhering to the current evidence-based guidelines. So we're able to provide that at no cost for 3 years for new hospitals that are participating with us. And so those that are enrolling this today or in the next 3 months will receive that for the entire calendar year of 27, 26, and the remainder of 2025. We also have learning collaboratives and educational opportunities that we provide to participants that have continuing education credits. And then we have peer-to-peer networking platforms and ways to connect and learn from other facilities who have models to share where they've worked on their quality to adhere to the guidelines and have a process that might work for others. So it's been a really great program. And we can move to the next slide, Natalie, where we've been able to provide this to not only critical access hospitals, but any rural hospital that's geographically rural, and then newly to our rural emergency hospitals. We've recruited almost 600 hospitals in the last 2.5 years to this program, bringing us up to almost 1,000 hospitals that participate with us and that Some of them do multiple modules. That brings us to almost 1,400 that participate in a Get with the Guidelines program. More broadly, if we were to count in all of our urban facilities, we'd be nearer to 3,000 hospitals that are in the Get with the Guidelines. And why that really matters is because we have the ability then to benchmark against peer facilities to see how you're performing to hospitals that are like you and like your setting, and or if you want to do comparisons to the national benchmark, including the urban facilities, that's there as well. In the three programs, we developed tailored measures specifically for rural hospitals, and this is new. We didn't have this prior to the Rural Healthcare Outcomes Accelerator program, and therefore many of our rural hospitals, experienced, kind of limited measures that applied to the care they gave in our programs. And now since
Hello.
then, we've got lots of measures in each of the three programs that are rural specific. In stroke, we have 10. In CAD, we have 7 for ST elevation MI and 7 for ACS. And in heart failure, we have 6 that are relevant to all size facilities. And the unique thing about the performance programs in each of these three conditions now is that we have a composite available that rolls the numerator and denominator, so the care opportunities met within each of those individual component measures into a composite score that kind of tells you how you're meeting and how your care is lining up with the evidence-based standards of care for each condition. So that's been unique. And then with that, we can award hospitals for care excellence who have really low volumes. So we last year we were able to give out over 1,000 awards to rural hospitals, and these are national recognition awards that can be used in your communities to really share why and how you're making a commitment to care excellence for your cardiovascular and stroke patients. Next slide. So we'll kind of buzz through these. I know we've got a lot of great content to share, and I don't want to take too much time, but just to know there are 25 enrollments among 21 rural hospitals in Michigan today as part of these programs. So you can see those listed here. So if you're one of these, thanks for participating with us. And just know if there's another condition you'd want to expand your participation to, you can sure do that in these next 3 months and add another program if you're just in one or two. Next slide. And then next up here, we have the hospitals that are have been awarded. I think we went back, Natalie.
Oh, yep. Sorry about that. Looks like that one. Oh, there
So
we
these
go.
are the hospitals last year that we were able to issue those Care Excellence Awards to. This is kind of our first inaugural year for many of these hospitals participating in program. And it works like this. So a bronze level recognition is you met the care standards for 1 quarter. A silver recognition is you met it for 1 full calendar year. And then new for next year and not it'll be our first opportunity this year to issue gold awards for 2 years of adherence to those care standards. And, with these recognition opportunities being new, this will be the first year we've been able to give rural gold awards to any hospitals in the country. So as you can see, we had many last year who got silver and several who got bronze, and we're hoping to just keep building on the hospitals who are recognized every year. Next slide. These are the hospitals in Michigan today that are eligible to join a module as part of the Rural Accelerator at no cost for 3 years. So there are 64 hospitals here, and we're happy to share this full list after the call today or as a handout with all of you so you can double check to see if you or any of the hospitals you work with are on here that might want to consider joining. Next slide. And this is kind of our why. We always like to bring things back to the why. Again, I talked about those national numbers for outcomes and mortality deficits in our rural areas, but this really kind of breaks down based on the CDC Interactive Heart Disease and Stroke Atlas at a county level, how many deaths per 100,000 residents are experiencing in Michigan due to cardiovascular diseases and stroke by kind of color wheels. So the lighter pink Gray is insufficient data, but that light pink is that lowest quartile, and then the dark red would be the highest quartile of risk. So you can see there are, certain swaths of Michigan that are higher risk than others, and usually that correlates to where the larger hospitals or the larger populations are. Or the lower population. So take a peek at that. If you're curious about your specific county, we certainly can share that information with you individually. Next slide. In the states where we've had a lot of cardiovascular and stroke program, we've really been able to make a change in those mortality maps. Like here in Minnesota and North Dakota, we've seen a lot of them change from darker red up to those lighter shades of pink over the years. And so I've experienced firsthand that our programs and care coordination really do make a difference. It just takes a few years to start seeing those on those maps. As part of the program, we do have convene hospitals and quarterly learning collaboratives for each condition. We have hosted, I think, 27 of these now. We just had our stroke quarterly collaborative this week, in fact, and over 6,500 participants have registered for those. And many have attended the live sessions, but we always make them available as a recording too. So if you can't make the live session, you can always just view the recording when that timing works for you. And these are so great because it's where we do things like Angela's going to do today is share model practices and hear from hospitals who are really doing this every day and how it's impacted them, little lessons they've learned, protocols they've put in place, orders that have made a difference for them, and learned a lot about BPAs and lots of things. So they're a wealth of knowledge. And then we share as program consultants tips on how to use the registry and reports to the highest advantage for you. And then any changes to the programs that are coming down the pipeline, we give you a heads up on those so you can be prepared for any changes that we make because we're always learning and enhancing the programs to better meet your needs. Next slide. Some of the resources we develop with the focus groups that we pull out of the learning collaboratives. This is small group work, like 6 to 12 people really diving in and giving their perspective as a clinical expert practicing in this setting to develop resources. So these are just some of the things we've put together, and some of them are still pending review and will be released this spring. But as you can see, there's a wide variety of tools and resources that we've been able to put together with the help of all of you to really guide the content and what would be useful for you in your daily practice. So I just wanted to share a few examples of the things that we have available that are developed in partnership with our participants. Next slide. And from here, I think we're going to move on to our model share, and Natalie's going to go ahead and introduce Angela. Thank you. We'll take any questions you have in the chat, or we can come have some time at the end for folks to come off of mute.
All right. Thank you, Mindy. Get this queued up here. All right. First, I'm just going to read the disclosure here. So the recommendations and opinions presented by our guest speaker may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA, ASA. The AHA and ASA does not endorse any product or device. And now, without further ado, it is my pleasure to introduce Angela Schiller. Angie is a dedicated healthcare professional with a robust background in nursing. She holds a Bachelor of Science in Health Science with an emphasis on health administration from Grand Valley State University and an associate's degree in nursing from Muskegon Community College. Angie has extensive experience working in various medical settings and is a stroke certified registered nurse. Currently, she serves as the Critical Access Program Coordinator for Trinity Health Shelby Hospital in Shelby, Michigan. Angie, the floor is yours.
All right. Well, thank you for that. Yes, I am the trauma program coordinator, the stroke program coordinator, the chest pain STEMI program coordinator. Really, that became too much of a mouthful. So my director of nursing gave me the title Critical Access Program Coordinator. But then what program do I run? All of them. Just know that that title now means that I run all of the programs, I feel like, But I'm not alone because this is rural health that I'm speaking to, and you all understand what wearing many hats means. So, um, just wanted to share a little bit about myself now. I love my job. I love working for Trinity Health Shelby Hospital. It's a great hospital to work for. I've enjoyed my 13 years here so far. I'm also a wife and a mother of three, ages 12 to 17. They're actively involved in their church youth group basketball and volleyball. I coach basketball. Our varsity team's been conference champ. You can see right there. Woo-hoo. Go Heart Pirate. And our JV team ended with a 20-1 season. I only missed one game. Guess which one it was? Look at my record. It was the one loss. So I'm also the interim youth director at my church. You can see a picture of the retreat we just went on a couple of weeks ago. And I'm also the chief cook at my house. And I promise you, dinner is always on the table at 6 every night we're home. So that's a little bit about me. Next slide. I have no disclosures, none at all to give you. I am who I am. Now that you know a little bit about me, let me introduce you to Oceana County. Oceana County is the asparagus capital of the nation. That's right. With a population of 26,000, we are known as the asparagus capital of the nation. We're the leading area for asparagus growth and also fruit trees. In the entire country, we've been celebrating asparagus since 1974, complete with that asparagus queen. Now I am talking rural health language, aren't I, when I start touting the asparagus queen. We also have a Silver Lake sand dunes that are really popular. It's the only sand dunes east of the Mississippi River where visitors are allowed to drive private motorized vehicles over the landscape of sand. It runs April 1st through October 31st. It brings about 1.6 million people and visitors. Remember, we're a population of 26,000. And over the summer, we see 1.6 million visitors to the dunes. And then on top of that, we have a very robust tourism in our county. And during that season, the beaches along the lakeshore really do provide a lot of tourism as well. So we see about 2 million people that come to our small little county, and they do keep our small 7-bed emergency department very busy. Along with that, of course, we do have we do have the agricultural tourism, but we also have entertainment. So as you can see there, we do have a 5-day long festival. It's a music festival, and we call that the Electric Forest. It also comes to our county every year. So that's a little bit about the county. Next screen, please. I want to share with you a little bit about my hospital. I say my hospital because I love it. I love our hospital. I love our community that we get to work for. We do serve Oceana County, which, like I said, has a population of 26,000. It looks like our age-adjusted rate for heart disease and stroke deaths is about 423. We have a 7-bed emergency department. We're a level 4 trauma center, DNV certified acute stroke ready hospital. We are a newly accredited chest pain center as well. And in 2021, we were named in the top 100 rural and community hospitals. In Michigan, we happen to be, well, this is actually nationwide in the United States. And actually in Michigan, we were just one of 2 that were offered that recommendation and that acknowledgement. Our hospital does have 24 acute care beds. We see about 108 stroke alerts, 92 traumas. We see chest pain patients, 30 to 40. We have 1 to 2 STEMIs a month. And we do have 24/7 emergency care. I love that phone call. I work in the emergency department as well, and I love that phone call in the middle of the night that says, "Are you open?" And I want to say, I answered it, emergency department. Of course, we're open, but instead I said, "Yes, how can I help you?" We have internal medicine as well that's combined with our local hospital that we share with in Muskegon. So we have a lot of continuity of care between our emergency medicine and our internal medicine. We have general surgery. We've got outpatient surgery, podiatry, urology. It's amazing all the things that we can provide in our small hospital. And we're very excited to do it. All right, next slide. I want to share with you a little bit about what our stroke program looks like, but I can't do that without first starting to show you geographically where we're at. So you can see I'm a part of Trinity Health, and our system has a good showing over there on the east side, but also we have a good representation on the west side of Michigan as well. As you can see, the hub there is in Grand Rapids. Grand Rapids has the Hallenstein Neurological Center. Actually, they're doing their DMD survey right now as we speak. Good luck to Grand Rapids. But they are our hub, and we have three spokes that come out from there. It's Muskegon, Shelby, which is the one up to the north, and then Grand Haven was just added. It doesn't even have a little dot on our map there, but Grand Haven was just added to Trinity Health, and we're really excited to work with them as well. I guess to start out with this slide, though, the nearest primary stroke center that we have is 33 miles away. So if you are a rural hospital, my first advice to anyone in a similar position as mine is to attach yourself like a leech to another hospital. Make them bring you in, because I tell you, I could not make it without my other spoke and hub hospitals. They're really an amazing group of people. If you succeed, your spoke hospital really succeeds as well. I meet weekly with the trauma team in Muskegon. I meet monthly with our stroke team. We attend each other's committee meetings. It's really great to have the kind of support that I have. Grand Rapids right there is 57 miles away, and that provides care to our patients, but also the educational resources that I get from them to our colleagues is phenomenal. So again, if you have a hospital that you transfer a lot to, use them to your benefit. I really appreciate what Muskegon and Grand Rapids has been able to do for my stroke program. Next slide. Here's a little bit more about my stroke program and our ED. We see about 10,500 patients in our ED each year. And then 108 code stroke alerts were sent out this year, which is up from when I started collecting data in 21. And I just kept getting better at finding strokes within our Epic system. And also we became known as an acute stroke ready hospital. So our numbers have increased. All right, next slide. I didn't start out in the stroke program using Get With the Guidelines. How I did is I started keeping data on all the strokes in a log, which I added and subtracted, any data point that was beneficial or not. And then once I started using Get With the Guidelines, I used an abstraction entity to grab all of our diagnosed strokes that were either transferred, discharged, or admitted. I didn't grab all the code stroke alerts at that time, but the code stroke alerts are very important. So I still started keeping, I kept my own log for those. So I'm using two separate logs, which is sometimes confusing, but the nice thing about Get With the Guidelines, you can ease into it. Just have to go all in all at once. Our code strokes were extremely important as an acute stroke ready hospital to see that metric data. So even if it didn't end up being a code with a diagnosis of a stroke, I really wanted to make sure that we were looking at how long is it taking to get to that CT, how long is it taking to contact neurology, and how long is it taking us to get that TNK in. So you'll see a lot of data here, but the 108 is the total number of stroke codes that we had. Our stroke diagnosis was at a lower number of 63, which is 58%. And I'm currently trying to figure out how to get that all to work out. But it looks like we had 63 patients that were diagnosed with stroke or TIA. 44 of them were ischemic, 3 were intracerebral hemorrhage, 2 subarachnoid hemorrhage, and there we had 14 TIAs. Interesting to note that Get With the Guidelines gives you all that information with just a click of a pen. Median stroke age of 74. All Natalie had to do was just look for that data and it pops up. It's really a great system to be able to see where you're at. Next slide, please. So this gives us a little bit more detail about where my patients are coming from. We had 56% were female, 44 were male. And if you look closely there, you'll all recognize that slide down there at the bottom. Where do your patients come from, EMS or private vehicle? And if you're a rural hospital, you know that is a real fight. If our hospital's our ambulances are 20 minutes away from the farthest part in the community or the county. They're thinking to themselves, should I wait for EMS to get all the way out here, or should I just drive to the hospital? So it's really something I know that all rural hospitals do struggle with. But as you can see, about 56, that's probably on the high side for some of these rural hospitals. It's probably on the low side, excuse me, for private vehicles. I know a lot more people in the rural areas drive by car. And then EMS brings in 42% of our strokes. As far as where do they go? Where does this small hospital, 24 beds, send our stroke patients? Well, 58% of them do go to a tertiary center, either Muskegon or Grand Rapids. When we do admit some of our patients, 30% of them end up going home. 7.3 go to a skilled nursing facility. And then, of course, we do have the expired at 3%. Next slide. So that's just the numbers of our stroke program, but I want to talk to you a little bit about what our stroke program looks like and where it came from. Our stroke program started in 2021. The stroke committee actually was created. Can you switch to the next slide? And then I'll have you come back to this slide again. This is a preview of who we have in our stroke committee. And I wanted to show you because it's interdisciplinary. The more disciplines that we can have involved in stroke care is really a great, it really shows what our hospital is about. We have higher level management. Our VP of operations is in our stroke committee. Our director of nursing is in our stroke committee. We have our radiology manager in our committee, as well as our rehab manager. And on top of that, we've also got a lot of input from nursing leaders, people that are actually doing the work, radiology techs who are actually doing the work. We have our pharmacist our pharmacist is here 2 days a week. So we do have to do a lot of our own mixing of TNK, but in the meantime, they're very helpful to us in making sure things happen. We have internal medicine and our emergency providers, all a stroke medical director as well, that all are part of our committee that really help coordinate care and solidify our care that we give to our stroke patients. And then just down there at the bottom, you'll see it says Regional Trinity Health Hospital Stroke Coordinators. And I don't think I can emphasize enough how great it is to have support from other local stroke coordinators, and their ability to help and support me has been phenomenal. All right, can you go back, not up, but back to that last slide? There you go. So also, I just want to touch on our stroke program does have provider consistency. What I mean is that we share our ED providers and our internal medicine providers with Muskegon. So what we really try to do is stay as consistent as we can between the two hospitals. Obviously, we're smaller, so we can't do everything like they do, but mostly we can be streamlined so that there's no question from the provider. Oh, well, I'm in Shelby today. How do I do this? I'm in Muskegon today. Am I supposed to do it different? So that's been really incredible to see their buy-in as well. Stroke order sets are completed at both hospitals exactly the same. That in itself is amazing. So that's really a plus for our stroke program. We do offer ongoing education. I am a certified stroke registered nurse, and we had a grant that actually allowed 4 of our nurses to get this education and to take the test. And incidentally, when I'm talking about the help and support that I get from Grand Rapids and Muskegon, we actually have a hospital educator that works in Grand Rapids that gave us all this free education to get this SCRN grant. And also that they're very involved with our EMS education, as well as me educating our colleagues here at our hospital. So they also help out with ongoing annual education as well. And I'll talk about that in a minute, because this hospital that I work for is just really clings to our education and actually uses it. And I have a graph to show you. Just a little bit about our inpatient stroke program. We didn't always admit stroke patients, but then you see the increase of emergency holds and how long people are having to stay in emergency rooms in the bigger hospitals. We really saw the need to really increase our inpatient care for stroke patients. So we did have a mobile MRI unit. We still have that, but we've increased hours for that. Our rehab went from, well, if you have a patient, I guess we'll come up and see them, to 5 days a week. They saw all of our stroke patients within 24 hours. And now, knowing what need that we have, we've actually gotten 7 days a week within 24 hours. All rehab, OTPT, and speech are seeing our patients up here under the metric that they're supposed to. And just seeing how our inpatient staff has completed the appropriate metrics on time is amazing. And it'll be shown in the Get with the Guidelines slide that I have coming up as well. But the point here is invested colleagues really make coordinated changes. And that's what I've really poured into, is getting our colleagues invested in the stroke program so that we can make the changes that we need to. All right, go down 2 slides if you can, Natalie. Yep, that one. Okay, this is the first graph I think I ever did as stroke program coordinator. This is not with Get with the Guidelines, because we didn't have Get with the Guidelines when I first started. But this just is a graph that shows the changes that occurred in our stroke care from before they received education on stroke and after they did. So the blue will show our pre-education time and minute when we look at door to doc, door to CT, door to stroke scale, door to blood glucose. And then the orange shows post-education. So as you can see, maybe door to doc time didn't change a ton, but right here, door to CT, we were almost taking 50 minutes to get our stroke patients from the door to the CT. And that, that's unacceptable, right? Well, as soon as I started educating our colleagues, we were able to get that down to, well, it's much lower now, but again, this is from 2021, I think. You can see that we were getting CT, a patient to the CT in less than 30 minutes. And then our stroke scale, our door to stroke scale was greater than 50 minutes. We were actually waiting 50 minutes before we assessed this patient and giving them a stroke scale number. But as you can see, after post-education, we got that number down to about 15 minutes. And then door to blood glucose, we were waiting for the BMP, not getting that initial blood glucose. So we saw some immediate results, going from 50 minutes down to just under 30 minutes for that blood glucose. Again, this is the beginning of the program, so we have better numbers now. I just wanted to show you this graph to show you how amazing our colleagues are to really making changes that need to happen for our stroke patients. Next screen. So why Get with the Guidelines? So this is just something that was offered to us. And when I heard that it was being offered to critical access hospitals, the rural health program, that my first thought, was I want in on this. Like, knowing our resources were low, like we needed to act now and get this done. At the time, I had no idea how much Get with the Guidelines really had to offer. But what I did know was that my community, Oceana County, was going to get their information into a place where it could be used and studied and researched with an organization, American Heart Association, that's proven over the last 100 years that they can create miracles in improving healthcare across the nation and world. Now, before you zone out, just want to share with you, like, this is really, this is very much of a passion of mine. When American Heart Association was founded back in 1924, cardiovascular disease and stroke was considered really deadly, right? No treatment. I mean, if you got that diagnosis, you were put on bed rest and you just died. Like, there was no hope. But now fast forward to today, not only are there treatments, but there's proven ways to lower your risk for heart disease as well as stroke. And it's not just because of the American Heart Association, but through scientific research completed by American Heart Association, there's a deeper understanding of the many factors that contribute to heart disease and stroke. And now cardiovascular disease is treatable and in some cases reversible. I mean, the amount of strides that American Heart Association has made for overall health in the last 100 years is really, it's phenomenal. And not just for America, but for the world. So through the years of scientific research, the disparities in communities, it's been realized, right? Like, our rural health areas are struggling with healthcare. American Heart has come to acknowledge these lack of resources in rural communities, and it obviously leads to, a higher capita mortality. And now that they've done so much for the general public, American Heart is not just stopping and enjoying the limelight of the last 100 years of improvements. They're now looking for ways to improve care in our rural communities and to combat health and cardiovascular disease right here in our rural communities. I am a critical access program coordinator. I work in the emergency department of a rural community. I'm constantly visualizing and seeing firsthand the effects of the lack of knowledge in our patients, and it shows up through decreased physical activity, lack of provider resources, lack of community awareness of disease, and other factors as well. But all of it leads to poorer outcomes. Our resources for Shelby are more than 35 miles away. And most people don't even have available access to receive these resources, let alone know that the resources are even out there. So yes, I heard of this program and I wanted in. The thought of Oceana County being a part of this organization and having an opportunity to be a part of, pushing health advances into rural communities was very exciting to me. Honestly, in 25 years, I want to look back at how the American Heart Association has changed rural healthcare. And I want to see how we handle stroke and cardiovascular disease differently in rural communities. And I want to be able to say, oh, hey, I had a hand in that. I was able to make that happen. So that's why we really chose Get With Guidelines. One of the reasons. Of course, the metric outcomes are really important. I can easily check door to provider time, door to CT time, TNK administration time. Like all these things, I have the opportunity to check right away. So metric outcomes are obviously very, very also staying current on stroke guidelines. Rural Healthcare Outcomes Accelerator, they do a, we just actually, I think maybe just talked about it. We do quarterly educational sessions, and they consistently show areas where metrics aren't being made within rural communities. It really shows a pinpoints areas that we need to work at. It's also really extremely helpful to hear from other rural health program coordinators. Because you always know that somebody has it worse than you, right? You always a fire alarm going off here. So if I start having flames go off behind me, I might leave. All right. Recognition opportunities. Last but not least, one of the main reasons why I chose Get With the Guidelines is I love affirmation, and Get With the Guidelines gives me just that. So when Trinity Health Shelby does it right, our facility gets recognized. And my love language is affirmation. So I love that recognition. Next slide. That'll show you what we look at. So this is what Get With the Guidelines looks at for stroke rural acute measures. Just to kind of give you an inside look at that. They do offer, just like the Olympics, that's how I feel like it is, bronze, silver, and gold. And they look at metrics that you make, like the stuff you're already doing, but it's just pushing you to get better. So door to CT time, are you doing swallow screens? Are you getting your TNK in under 60 minutes? Do you have a good relationship with EMS if they're giving you pre-notifications? Are you getting into that CT in time? Are you getting results from your radiologist in time? And are you getting that neurology stroke consultation? So really, if you want to show the next screen, I'll show you how we did our very first year with Get With the Guidelines. So this is straight from Get With the Guidelines. This is a printout that they'll actually give you. The goal is to have everything at 75% or higher. In other words, our rural stroke composite score there. We were at 82.4% in 2023. You look at that lowest one, and I know you all will feel for me because that 44% is door in to door out time. So I know that there probably isn't one rural health hospital out there that doesn't struggle with that. But other than that, we're getting everything done. You'll see a lot of 80s and 90s up there. Really exciting to see that. So the stroke scale that we do, if you can see that stroke NIH stroke scale, we're getting that done in the appropriate amount of time and 92% of the time. If you remember back to that original screen that I had, We were waiting greater than 50 minutes to get that done, and just to see the improvement that now we're doing it appropriately under 92 or 92% of the time. Let's go to the next screen real quick. So this is what we got in 2024. We got the bronze and the silver for meeting our rural stroke measurement. And then the next one, if you could go to the next screen, and Natalie, feel free to jump in if you'd like to. You know this better. All I see is an improvement, so that's great. 86 up from 82% from the previous year. We still got to work on our door in, door out times. I know DNV is actually looking into that to see if they can even alleviate that measurement, because it has been proven that it's not always our fault. But the times that it is our fault, we do need to look at that and figure out when we can improve those times. Again, looks like we were meeting all of our metrics. Our rural stroke composite score was 86% overall. You want to go to the next slide, or do you want to say something more about that slide, Natalie?
Yeah, I'll just say, this puts you essentially on target for a Rural Gold Award. So two years of achieving the composite score. So that's fantastic. We are super pleased.
Love the affirmation. Get with the guidelines just to have her say you get the gold. So that's one reason why I like it. Okay, next slide. We do accept inpatients. Whoops. Yeah, this one kind of shows targets that you can reach beyond that, the quality measures. So like we're looking at this, I'm trying to look at the bottom ones there. Because the honor roll elite, Natalie, am I right? Can you explain what like the honor roll elite and advanced is?
Yeah. So yeah, this measure set essentially looks at those the measures, inpatient measures, so those patients that are admitted. And then if you achieve an annual award with this measure set, then you're also eligible for what we call a plus award, which is looking at our quality measures. And so if you achieve at least 75% compliance on at least 4 of those quality measures, then you get that plus award. And then down here at the bottom, the target stroke section, this is kind of breaking down those door to needle times into different categories. And you must have a certain amount, you must have 6 patients to be eligible for that. And so a lot of times, that doesn't fit for our rural, but it is still definitely optional for for hospitals that can keep patients and transfer out. So
I think the next slide shows kind of where we're at with our inpatient measurements. So we're looking at, on the inpatient side, when we admit a patient to our floor, there's some definite measurements we want to make, right? We want to make sure that if this patient's in AFib, that we're giving anticoagulation, and that we're discharging patients on an anti-thrombotic. We want to make sure that we're giving early antithrombotics under 48 hours of having a patient in our hospital. We also want to make sure we're giving statin therapy. We also want to make sure we're giving TNK an appropriate amount of time. We want to make sure we're educating on smoking cessation, one of the biggest risk factors is smoking. So we want to make sure we're getting people to realize that. And also making sure our patients are on BT prophylaxis. I think one of the biggest challenges to starting the inpatient side of a stroke program was a stroke patient's a lot different than a patient that comes in for CHF, and we've got to decrease the load on their heart by giving Lasix. We're fixing a patient in that way. We're, a patient comes in and they've got broken rib fractures, right? We're helping with pain control. We're doing things to symptomatically help them. With a stroke patient, our biggest nursing intervention is education, because we don't want them to have another stroke. The percentage of patients that have a stroke, re-stroke out in their life is very, very high. Your risk increases tremendously. So we need to make sure that what are those risk factors. Your blood pressure has to stay within certain measures. Your blood pressure needs to be in control. Your blood sugar has to be in control if you're diabetic. So just changing the mindset of the nursing staff to say, hey, we're not fixing anything, we're educating. That's our care that we're giving to make sure that they aren't back here in 6 months with similar problems or worse. So that was really a fun part. And as you can see, we've been able to meet those metrics pretty regularly. All right, next slide. So the last thing I want to talk about, again, has to do with colleague investment into this program. And we realized at our last DNB that we weren't meeting a metric, or it wasn't a metric that we weren't meeting, but we just maybe weren't contacting neurology as soon as we could. We were looking at ways that we could improve our door in door out times. One of them was, are we contacting neurology to get this patient to a different facility if needed? And we didn't get that wasn't a nonconformity. It was just simply a hey, we need to work on this. So we decided through our stroke committee, multidisciplinary stroke committee, that we're going to add it to our algorithm, change our protocol, and we were going to actually follow like what Ms. Keegan did, and we're going to call neurology right away when we called the code stroke. So after we changed the protocol, go ahead, next slide, we ended up going from 45 minutes average time of calling our neurology and alerting them to 12 minutes. And I have to tell you, it was like the date was like pretty, like you could look at the date and see when I gave the education. It was pretty impressive. And this is what I get a lot in our hospital is that when I educate them, they have buy-in because they've been included on the decision through the nursing leaders we have on the committee, and they're actually making these changes, and you can see it in real time. And next slide. And last but not least, I know affirmation is my love language, but apparently also seeing a program run like we taught it to run for the last 3 years is too. This is a picture of the emergency department at our hospital, and I came in the back door after being at a meeting outside the hospital. I came in, and I usually do this. I come in and I stop in the ED, check in with them, and see how they're doing. And as soon as I walked in that back door, I knew exactly what was going on because there was a bed sitting in the middle of the hallway where EMS is going to pull up to it momentarily. The bed's zeroed out, and you can see that there's dangling from the IV pole is the vital sign machine that we've done like protocol. There's a stroke packet sitting on the bed underneath so it doesn't get weighed. And you can see the computer that's right there with getting ready to admit that patient as soon as that EMS personnel brings that patient in. We're going to get their name in there and we're going to register them. You can't see my admitting personnel. She's off to the left, and behind me, they wouldn't get in the picture, is the lab respiratory staff, our radiology staff, and the nurses that are all standing there ready for when that patient comes in. And I have to say, I'm obviously passionate about this, but to see the program that you've been working at for the last 3 to 4 years, really working seamlessly and exactly how it's supposed to, really just shows that Trinity Health Shelby Hospital is acute stroke ready. We are DNB certified to be able to serve our community, and we're really excited to be able to do it. So that's really all for mine. The next slide is just the ending slide, but does anyone have any questions, or did you have something else you wanted to do, Natalie, next? Thank you for letting me share. I really appreciate it. I love sharing my program.
Yes, thank you, Angie. That was a great presentation. I'll just touch on a few more things and then we'll leave, I want to make sure that we have time for any questions. This slide here shows what patient populations should be reported. So if you look at stroke, the required patient population is, those with cerebral infarction, those ischemic strokes, and then our intracerebral hemorrhage as well as our subarachnoid hemorrhage. It is optional to enter your TIA patients, as well as any of those stroke codes that end up being just a stroke mimic. And then optional to enter those subclinical, those with a last known well of greater than 24 hours out. And then, of course, your inpatient strokes, if they're admitted with another principal condition and they stroke on the floor, that is optional as well. So of course, with any registry, you get out what you put in. So, whatever works for you and your team is what you should be entering For our Get with the Guidelines coronary artery disease program, the only required patient population to enter is our STEMI patients. Your NSTEMIs and your ACS patients, chest pain patients, are optional. And then with heart failure, this program, of course, is going to look at those patients admitted and that hold a principal diagnosis of heart failure with or without CAD. Just to give you an idea of abstraction time, there's essentially three pathways for data submission. The most common by far, especially amongst our rural hospitals, is direct data entry, and that, just manually abstracting from your EMR into Get with the Guidelines. And, all of our programs really kind of hover around that half-hour mark per case. So if you look at this stroke example here, if you had 24 annual stroke cases, looking at just over that 30-minute mark to enter a case, you would be looking at 1.2 hours of data entry in a month. We do have some other things available. We have a data upload file that can be built that can help to upload up to about 85% of those data elements. And then, of course, we are compatible with several third-party vendors as well that can upload or can enter the data. I'm going to skip ahead a little bit because I just want to make sure we have some time for questions. These are the rural measure sets and recognition infographics, and I'll just include those along in the slide deck. But just wanted to speak a little bit about Rural Accelerator participation and what it entails and how you get there. There's a couple of agreements that need to be executed. There's what we call our Unified Participation Agreement, which is essentially the enrollment into the Get with the Guidelines programs. And then we also have a Rural Participation Agreement, which is that Rural Accelerator Agreement, which essentially then wipes that cost for the 3 calendar years of those programs. As far as the data schedule, it's best to stay as current with your data entry as you can. And we just ask that you start data entry within 60 days of enrollment. We offer lots of ongoing support. We have some onboarding sessions. We have one-to-one training sessions with your program consultant. We love it if you take advantage of our support and benefits and, designate at least one hospital team member to participate in those rural learning collaboratives. And, just reach out as needed. That's what we are here for. We're here to support you. Skip ahead here. So what are the next steps? So, discuss your Get with the Guidelines enrollment at no cost via the Rural Accelerator opportunity with your decision makers. Now is the time to begin enrollment. Just reach out to me. My email is first there. And just know that grants are available until June 30th. So we're in the last few months of our enrollment period for the program. So the time is now. So please reach out. All right. I think we do have about 6 minutes here. So if anybody wants to come off mute and ask a question, happy to take those either to myself, Mindy, or Angie.
Yeah, there's been a couple of questions in the chat, and it looks like Mindy's answered those. But if Jen Bentley or Jen Anderson have any follow-up questions, or if you feel like you need more information, please just take yourself off of mute.
I personally, Jen, use a data abstractor just to do some of my abstractions, but they do have to, I still have to go in and fill in blanks. They don't do everything. case you were wondering. It's helpful not to have to enter the codes. Diagnose codes are not my forte.
Right. Any other questions or anything we can elaborate on? I'm happy to do that.
Yeah, I'd encourage anyone, who's thinking about the program to set up time with Natalie to really look at if it's scalable for you and to dive into how much time might be needed to participate in the data abstraction and then walk through, what the options are and if those, are something you want to consider outside of the direct data entry.
Well, I wanted to thank Angie and Natalie and Mindy for taking time today for this presentation. We truly appreciate it. The webinar was recorded this afternoon, so that will be up and on the MCRH website soon. You'll also be receiving a survey for today's webinar, and I appreciate you filling that out and returning it. It's always great to hear your comments and concerns, and it's great information for us to have as we move forward with upcoming webinars. Not to take up anyone else's time today or any more of your time. Thank you so much again for attending. Greatly appreciate it. If you have any questions, please feel free to reach out and I can get you into contact with Angie or Natalie or Mindy. All right, everybody. Thank you.
Thanks, everyone.
All right, have a great day.
You too.
Bye.
Bye.